Okay, we're going to get started, folks. Oh, we don't have quorum? We're not going to get started. Okay. 1, 2, 3, 4, 5. Oh, they're conspiring outside. Yeah. Oh, they're okay. I'd like to call this meeting to order, just as the last two folks are seating. Welcome to the meeting number 22 of the Board of Health. Welcome to the board and to other members of council and tenants and to members of the public. These are, of course, always open meetings that you're always welcome to come and attend. For those in the room with us, the screen at the back of the room tells you what the real-time updates are, where we are in the agenda and what's coming up next. And if you decide to leave but still want to follow, you can go on your computer or tablet or smartphone and follow us at www.toronto.ca/council. You can do that at home for any of the meetings, frankly, at the City Council. The Board of Health gratefully acknowledges it is meeting on the traditional territory of the Mississauga of the New Credit First Nation, the Haudenosaunee, the Huron-Wendat, and home to many diverse peoples. We have a short by number agenda, but there are a lot of interesting things. Are there any declarations of interest pursuant to the Municipal Conflict of Interest Act? Seeing none. Confirmation of minutes, September 25th, 2017, moved by Angela Johnson. All in favor, opposed if any, that's carried. We'll go with a presentation first before we get into the formal agenda. We're holding, basically everything is being held one way or the other. There's only 5 items, and I can tell you in advance, there's either a deputation or there's a presentation. So we'll hold, the entire agenda is being held one way or the other, so we won't go through it one by one. But we do have a presentation right up off the top. Do you have notes on that? Do you want to go first or am I going first? Okay, I have that, so it's just me, not you? Okay. Okay, so in 2000, we're going to do a presentation around the Milan Urban Food Policy Pact Award. In 2015, the City of Toronto joined 148 cities across the world to sign the Milan Urban Food Policy Pact. The international pact recognizes that cities which host and house over half the world's population have a strategic role to play in the development of sustainable food systems and promoting healthy diets. Through the pact, cities like Toronto are pledging to work on developing food systems that provide healthy and affordable food to all peoples in a human rights framework, while minimizing waste, conserving biodiversity, and mitigating impacts of climate change. One important aspect of the Milan Urban Food Policy Pact is to foster the exchange of food-related solutions and innovations among cities. A mechanism for facilitating this change is through the Milan Pact Awards, supported for the past 2 years by the City of Milan. This year, believe it or not, City of Toronto's public health initiative, Community Food Works for Newcomer Settlement, won the highest score award based on adaptability, integration, innovation, impact, and inclusion. So this Community Food Works, which is what we're celebrating at the outset of this meeting, is a program that integrates food handler training and certification, nutrition education, and employment support through a learner-centered adult education approach. Brings it all those things, ticks a lot of boxes in one single program. It is offered to residents hoping to work in the food sector, many of whom have been living on a low income. When Toronto welcomed, very proudly, refugees from Syria to this city, Community Food Works was adapted to meet the unique needs of this newcomer community. This included cultural tailoring of the curriculum and the introduction of a peer-to-peer model of program implementation and interpretation. The program recognizes the importance of food as a vehicle for settlement and integration into the local community. It does this through enhancing employability, fostering social cohesion, and helping to break down language and cultural barriers. Early pilot results showed that of the initial 52 participants, 90% acquired food handler certification, and then 25% of them found employment within 3 months. Community Food Works for Newcomer Settlement could not be happening without the support and collaboration of our colleagues across the city divisions, our community partners, who I'll introduce in a sec, and newcomer peers who are here also today. Today, we are showing how integrating food literacy with food safety while addressing employment as a determinant of health can all come together in one newcomer settlement journey. So we're going to thank them individually, but before we do that, we have a wonderful video to show what this program was about.
I came from Syria. Back home, I'm a pharmacist. And now I work with community food works as peer animator, facilitator. I found this program very useful. I learned a lot of things. How can I deal with the food? To store the food in the fridge, how to use everything in the kitchen. I learned about how to read the label, the good ingredient and the bad ingredient in the food, like cholesterol, fat, sodium, sugar, very bad for the health.
I come from Egypt. When I came here, I didn't know anybody. Involved in this program helped me a lot. In my kitchen, for me, my kids, my husband, all my family, and back home, I told them what I'm learning. I'm a peer facilitator. I like to let the people know what I'm knowing from information, experience that I had from the program and the training, and especially it's in Arabic because nobody here knows English. If I speak Arabic, it will be easy for them to get it.
أنا سوري ساكن بحلب نعم، نحن كان بسوريا يعني أنا قليل أفرم أو أشوي، هي المدام كانت تعمل هالشيء. ايوه، تعلمت من البرنامج مسك السكين، الفرم الخضار، وكيف مندير على صحتنا بالنظافة.
أنا جاي من سوريا وإلي سنة ونص. بحب يعني إنه أسوي شغلات بالبيت، وبحبهم ياكلوا، ما بحبهم ياكلوا من برا، يعني لأنه هن قالوا لنا إنه الأكل برا مو كتير صحي. يعني أنا بحاول إنه ما ياكلوا أكل برا، بحب إنه أنا أطبخ لهم، وأكتر شيء بحبهم ياكلوا خضرة، كمان خضرة وفواكه.
In our country, we eat everything in natural, and we make it by our hand. But here it's different, everything in can. It's very healthy for us to keep our traditional food. But we can also use the new food for us, but in our way. We can add something from us, from our culture. We make it very good for us. Yeah.
أنا من سوريا، إجيت بأيار 8 أيار 2017. لأنه نحن جديدة بكندا، أنا جديدة بكندا، فنحن بحاجة لحتى أنه نندمج بالمجتمع الكندي ونتعرف على ثقافة الطعام الكندي يعني. فنحن بحاجة من الكورس ليفتح لي بواب شغل أو نتعرف على ثقافة الطعام بكندا.
I came from Syria and I have been in Canada like almost 2 years. When I came here, I decided I will be like accountant or I will make cakes. For me, I attend that program. I have the food handler certification, and then I take like a cake decoration course. Having a good job make your life easy. So when I found job, I feel in peace. Like I have my job, I have my money, I can take care of my children. My future dream is to have my own business because I have that food handler certificate. So I have power to do that. That's why I want to do that in the future.
We need job to survive. Like that, without job, without work, we cannot belong to this country. You know, a lot of women, they found a job from this program. They work at school, they work also at restaurant. They got a lot of job from this program.
صار عندي أصدقاء عراقيين، أصدقاء سوريين، يعني أصدقاء اللي كانوا ساكنين هون تعرفت عليهم، يعني شغلة ممتاز.
إنه يعني نحن اجتمعنا، هو أحلى الشيء لما حسيتهم مثل إخواتي. يعني أنا صحيح إنه إخواتي بسوريا، بس إجيت لهون لقيت أهل وإخوات كمان. أنا بحبهم يعني مثل إخواتي.
Before this program, I was alone. Now I know a lot of people from our country, Canadian people. I know a lot of things about the culture in this country. I want the program to be forever.
Wonderful. Thank you very much for that. Last week, Dr. Davila, Barbara Emanuel, and myself, we accepted the award on the health unit's behalf and on the City Council's behalf, and we were just delighted to do that. Internationally, believe it or not, Toronto is seen as a real pathbreaker in the area of food security and the way we have an inclusive and social equity approach to doing that work, and because of also our work with the Toronto Food Policy Council. They think we're the cat's meow, and you know what I said to them is, wow, but you know what, you ain't seen nothing yet. We're gonna do even more, and some of that, of course, is on the agenda before us in items number 4 and 5. So let's do some thank yous here. We would like to thank and welcome the peer educators from Community Food Works for newcomers who are here today, and they are, and you know what, don't stand up. We're gonna applaud you all at the end, and we're gonna invite you all to come up and take a picture with us. So it's Fadia, maybe just stand up, Yes, as I call your name, yeah, okay. Nawal, okay, Lena, also not here. Both stand up, both Lenas stand up, yes. Okay, there's one. Iman, there you are, oh yes, the star of the video. And Weibi. Oh, yes, also the star of the video. Great. And Marian Yosef, the TPH Nutrition Promotion Consultant and Program Coordinator. There you are. Well, congratulations. Let's give them a round of applause. Yes. And they were aided and supported with folks from Toronto Employment and Social Services, Devi, Lorella, Chiara, Angela, Tina, and Tony. Can you stand up? Oh, thank you. With, of course, support from our Toronto newcomer office, Vera Dodic, actually. Working Women Community Center, I see Marcy's here. Marcy, Luann, Sylvie, Chantel, Lucy, and Hanan. Do you want to stand up? We can recognize you. Flemington Health Center, the Fairview site, Shobha and Maria. And last but not least, the North York Harvest Food Bank, Shahar and Ryan. And of course, the filmmakers who were Arlene Moskovich and David Atkin. Stand up. Well, so we have something, this is a photo op moment, so if all the people that I mentioned would kindly come up and we'll take a picture, and maybe back here on this side of the hill, it's just a little bit more room. So what Dr. Davila has is actually the award from the Milan Food Policy Pact. So
You haven't had a chance to see it, so I feel like I need to show it to her.
we'll pass it around during the course of the meeting.
Yeah, we'll pass it out. Okay, do you want us to hold it? Yes, I think it'll be lovely. Okay, perfect. And you,
Okay, we'll go
should
around.
be also.
I'll go around you.
Come on in. Everybody's to be short.
So that we see her face.
I'm just gonna move the chair.
Okay, sure.
Yeah, and then you guys can actually move it up a little closer. And like you're closer. Yep.
Is that better? Can everyone smile? Oh, I'm looking at the other back.
Can I take photos?
Take it and look back there.
What happened to our chair?
Congratulations.
It's such a big thing. I know. When I first house, I went to a cooking class, Sherborne, near Wellesley, and they were teaching people how to cook because they didn't know what hot vegetables were. Same sort of thing. It's amazing. Yeah, it's really good. Yeah, they fed me.
They did or they didn't? Oh, good. Bonus.
I know. That movie was making me hungry.
Touch base with
Oh, yeah.
We'll keep that in mind closer to.
You can take as many pictures as you want outside. They'll figure it out, yeah. Okay, thank you very much. That was a good moment. So we have 5 items on the agenda. 3 have deputations, 2 have presentations, and 2 have motions. So we'll go through them one at a time. Our first item is 22.1, the deaths of homeless people. We have a presentation there. And just by the way, we also have a presentation from the MOH for 22.3, reducing health risks from traffic-related air pollution in Toronto. Those are the 2 presentations for the day. So first, death of homeless people, Dr. Davila.
Thank you, Mr. Chair. So I believe we should have some slides coming up on the screen in respect of this presentation on item 22.1. It's a progress update on reporting on deaths of homeless individuals in Toronto. And this is an update for the Board of Health on this very important initiative that was launched earlier this year. And the purpose of this initiative was to address limited data previously collected on individuals who have died while homeless. This is an important public health issue for our city. It contributes a great deal towards health inequalities and inequities facing vulnerable residents in our city. And the notion behind this initiative was to provide more data so that we could have a more thorough, a more fulsome understanding of the scope of this very complex issue in our city. So again, on the notion of background, we know that homelessness is an important issue in Toronto, and it does indeed affect some of our most vulnerable residents and contributes to health inequities. We know that the last time a street needs assessment was done in Toronto was in 2013, and at that point, the estimate was of about 5,232 homeless individuals each night in Toronto. These are street needs assessments that happen on a regular basis, and the next one is actually scheduled for next year. However, despite that needs assessment process, until this year, gathering data on individuals who've died who were homeless but were outside of the city shelter system was actually quite difficult, and we ended up with rather incomplete information on those who died while homeless but were not part of the city shelter system. And the issue with that is that it's very difficult to actually resolve or address problems when you don't have a thorough understanding of what the problem is and what's at its root, right? In order to come up with effective and efficient methods by which to address a problem, you actually have to understand that problem. So in response to this lack of data, City Council directed us at Toronto Public Health to collect all relevant data related to the deaths of homeless individuals, both within and outside of the city's homeless shelter system. And this is clearly within the mandate of Toronto Public Health, as one of our key roles and objectives in terms of supporting the system is to ensure that as decision makers, we understand and are aware of those issues which actually impact the health status of our citizens. So this particular data initiative, to actually get a more thorough picture of that which is happening in respect of deaths amongst homeless individuals in this city, started on January 1st of this year. And this is an effort that we're undertaking in collaboration with a series of health and social service agencies which provide service to homeless people in Toronto. In addition, we're partnering with the Office of the Chief Coroner of Ontario. And again, the notion behind this is to get a better picture of what's happening. So through this initiative, you can go to the next slide, we have over 200 health and social service providers and agencies working with us to collect data on individuals who die while living on the street or at a friend or family member's place, at a shelter or other locations in Toronto. And as I mentioned earlier, the idea is to get a more fulsome picture of those who die while in a homeless or precariously housed situation. In order to make sure that we're doing right by providing the data, every report that's received through these partners and agencies has to be reviewed and checked to make sure that we're not providing duplicate data or triplicate data for that matter. And what also happens is that each report we receive is sent to the regional coroner's office. And for some of the reports, there actually is a proper investigation by the regional coroner. And those are particular circumstances that lead to that. So when we're talking about deaths that are suspicious or unexpected, those are the kinds of deaths that the coroner does further investigation into. And once that investigation is complete, data from that investigation are then, again, verified and included as part of our system when it comes to reporting these deaths. So to date, insofar as this initiative is concerned, of the 70 reports that we've received on homeless deaths in year to date, 32 of those cases have actually gone on to further investigation by the coroner. So when we talk about what kinds of data we're collecting from our partners as part of this initiative, what we're including are such things as the deceased individual age, gender, and indigenous status, and these are things that are asked for as part of the reporting. Whether the people reporting can actually provide these data depends on whether they actually know or have any sense as to those particular points. We also ask people who are reporting on these deaths to give us what information they know on such things as the date, the location, and their understanding of what the cause of death might have been in that case. We ask for information as to whether the death occurred indoors or outdoors. We ask for any information the reporter might know or the person reporting might know about the individual's previous health status prior to the death, their history of homelessness, that kind of thing. And we also get the contact information of the person reporting the death such that we can actually follow up should there be further questions that arise. So the important part here to note, though, is that these are quite sensitive data, and in many cases, these are personal health information under privacy legislation. So we do manage these data very, very carefully, and all data collected under this initiative are treated as confidential. So now turning to the next slide, we can take a look at the results we've got to date. And, you know, I'll be very upfront with you. We had hoped, so prior to this initiative, we were receiving data in respect of deaths amongst those who were associated with city shelters. And we were expanding as part of this initiative to beyond the city shelters to get more information. And we were hoping that there would not be much more. But in fact, as you'll see here, we do know that there are a number of deaths that we are now picking up as a result of this new initiative that wouldn't have been caught if we were using the old system, right, where only those deaths that occur within the context of our shelters are known to us. So not entirely unexpected, but these are our data so far. So for the first 3 quarters of this year, we received reports on the deaths of 70 homeless individuals. And as you'll see on the chart in front of you, the blue bars on the graph represent the quarterly totals. So you'll see that there were 27 deaths reported in the first quarter of the year, 21 deaths reported in the second quarter, and in the third quarter of this year, 22 deaths. This works out to about an average of 1.8 deaths per week. Now, I should advise you that we're still relatively early on. This initiative started in January of this year. So, and there are still some of these cases that are under review, because it does actually take quite some time to make sure that we're assessing the data properly. So I think at this stage of the game, it would be wise, we're reporting these numbers to you so that you have a sense as to what's happening. But I would advise you to consider this these as preliminary numbers for now to be on the safe side. Just in terms of details or further detail with respect to demographics, the majority of those reported in the system were male, so 57 out of 70, which is roughly 81%. And the median age is, as you can see here on the graph, the median age of those deaths reported is 48 years. So this means that approximately half of the people were less than 48 years old when they died, and those are the reports received in this system. It's important to note that the life expectancy in this city, when we're talking about the general population of Toronto, is 79 years for men and 83 for women. So again, as I mentioned earlier, the initiative is still fairly new. We're still early in the data collection process, and the numbers as a result are still subject to fluctuation. New reports coming in can adjust and change those averages and medians very, very quickly. However, I think it's fair to say at this stage of the game that based on these numbers and what we know from the system in general, what we know about homelessness and its impact on health, is that being homeless is absolutely a significant risk factor for early death. Turning to the next slide, we are presenting some information in respect of location of deaths, such as they're reported in the system. And as you can see here, the majority of cases that have been reported to us through this initiative die indoors, and in fact, they're largely in inner city hospitals or at shelters. And so that's what we're seeing here on this slide. I would like to point out to you, however, that at this stage of the game, early in this initiative, it's not really possible to make meaningful geographic comparisons because we're still relatively early on in this initiative. So as you've heard me, offer advice to be cautious with respect to the data, I think what I'm trying to convey to this board is that in fact there are a number of limitations. These data, this initiative has taken us further, absolutely. We now know more than we did prior to January of this year in respect of deaths that happen amongst this population. But there are, and there continue to be, a number of limitations with respect to these data. And I've tried to articulate quite a few of them thus far. We know that, as we continue with this initiative, our hope is that we'll be able to address more and more of the limitations such as they exist. Certainly more numbers allow for us to make greater comparisons, whether we're talking about geographic comparisons or to really understand what the true demographic nature is as we move on in terms of time. But we're also trying to figure out and have to determine what impact there is with respect to not quite self-reporting, but reporting with respect to deaths from people who are not actually health professionals. You have people who are well-meaning individuals who are trying to help us understand this particular situation, but as we get more practice and as the initiative takes hold a little bit more, we're hoping to refine and make sure that we're able to ascertain those data and ascertain the risk factors associated with the deaths so that we can actually work with partners to address the situation. I think one gap I should alert the board's attention to is that we don't yet have hospitals included in the reporting system. This is something that we're actually actively working through with our hospital partners, but we do have to recognize that one of the challenges is that we are dealing with personal health information. Acute care facilities like hospitals have very specific requirements under privacy legislation, so we're in the process of working those issues through with them. So with that, despite all those limitations, I do believe we actually have much better data than what was previously available before this initiative. We know that the previous data were limited to those individuals who were living in city-funded shelters, and so as a result, we did not really have a complete picture. I don't know that I can tell you that we yet are at that complete picture point, but we are getting closer and closer to that. And I think that as we get closer to that and as we continue to work with partners who provide services for this very vulnerable population, we're ensuring that the information that we have is being shared with them so that they can address their programs and services in accordance with the data as they exist. So I expect that you will hear more from us, more from Toronto Public Health on an ongoing basis. One, as this initiative continues, and two, as we work with our partners in respect of meeting the needs and addressing the needs of this vulnerable population. And I expect that you will hear from us as we seek to address some of the activities and connect some of our activities to other strategies that are in play in the city, for example, the poverty reduction strategy. So in conclusion, This is an initiative that has actually advanced our knowledge. It is still very much in the early stages, but we are starting to reap the benefits from it because we actually do have more information, more than ever before, in respect of deaths in this population. We expect that we should continue to work with partners. As I said, we continue to bring on social service agencies and providers to help us report on these data. And as well, we're working with hospitals to increase their likelihood and ability to report so as to get an even more complete picture around homeless deaths. I think that brings us to the end of this presentation, and I'll turn it back over to you, Mr. Chair.
Thank you, Dr. Davila. We do have one deputation before we invite questions from the board. But just so people know the division of labor, this is not the Board of Health does not run the Shelter, Housing, and Support division. This does not directly, this is not a discussion around that. Our task as the health unit, as the Board of Health, is to ensure that the number count, the deaths of homeless people are counted appropriately and that they inform other departments on what they should be doing. So the action doesn't happen here. However, if there are questions related to that, we do have Paul Raftis and Marianne Bedard is here to answer that. They're from our Shelter, Housing, and Support division. So now we have our deputation time. We have one deputant, Patricia O'Connell, Executive Director of Sistering. I'll invite staff to make a little room. Thank you. Welcome, Patricia.
That is definitely a sobering presentation from the Medical Officer of Health. I'm here today because 2 of our women passed away in the last few months, one from an overdose and one at her own hand. The woman that passed away at her own hand was a lovely young woman, talented artist, really a terrific human being. She volunteered at Sistering, but she had a troubled life. She lived in the wooded area around the R.C. Harris plant for a year. Before her death, she was living in High Park, in both instances in a tent. After she passed, her mother gave me her tent so that other women could have access to it. So Nicole's tent hangs in my office, available to any woman that needs it. And I asked to be on the agenda here today because death of homeless women in particular, homeless anybody, is a tragedy in the city, but because I work day in and day out with women who have complex health histories, mental health issues, addictions issues, and these women literally live at Sistering. For those of you who don't know, we're a 24-hour-a-day, 7-day-a-week drop-in center. We've been in existence as a 24-hour unit for 2 years. We've been in the city for 35 years. We were funded by the city 2 years ago to open 24 hours a day because a woman was sexually assaulted downtown on the streets of a city-funded facility twice in one evening by 2 different people. And so Sistering was open to be what's called a low-barrier shelter, a shelter for women that are not welcome in other locations. So due to our women's behavior, they can't usually access the shelter system. I have one woman, 79 years old, who was evicted 2 years ago, and she shuttles between us, Evangeline Shelter, and Women's Res. 79 years old, incredibly complex health issues. At Sistering, she sleeps on 3 kitchen chairs put together. At Sistering, we have 12 reclining chairs. The winners of the lottery get the chairs to sleep in, then people get mats, and then they get the floor. Sistering has been at capacity every night for over the last year. Recently, the city added 35 more mats to Fred Victor, the Adelaide site. They're full. The city recently added 30 more beds to the Kennedy Women's Shelter. It's full. There are no places for women to go in the city for safety. We have women still outside. We have yet to turn a person away. I cannot imagine what it would be like to tell a woman she can't come in and have some safety. But we may get to that point because just for the safety of staff and women, we have a finite space, and as it is, when women are sleeping on the floor, they turn over, they're in the face of another woman. So it's a terrible way to live, to exist, and you just got an award for being a hotsy-totsy city, and we're not dealing with our most vulnerable people. And we desperately, desperately, desperately need more shelter beds. And in my case, we need shelter beds for women who are mentally ill, who have addiction problems, who can't go anywhere else. So if they can't come to sistering for whatever reason, there is not a place for them in the city. Our TC Lynn partner said in response to a survey that, of course, sistering has to exist. They're the lowest of the low. And my time is up. My request to you, sorry? Okay, my request to the Board of Health is two things: that you report to Council on the absolute dire need for shelter space for hard-to-serve women, for women whose behavior is not tolerated in other locations in the city. Desperately, desperately need this. And I've made a request to anyone I can think of. I need mental health nurses, one nurse on every shift we have. So 7 days a week, 3 shifts, I need a mental health nurse. I haven't been able to get anyone to fund that, and that would go a long way to helping our women. And I think I haven't met Councillor Fletcher, but the shelter needs to be in her ward. That's where a whole bunch of our people come from.
Thank you very much. You have a question from Councillor Layton.
Thank you very much. And you really did answer the first part of my question, but I will get you to answer it again. What is it that you need as a frontline organization at capacity that is struggling to keep up with demand?
We are at the point now that we need additional staff. So the city provided the staff for the extended hours, and the TC Lynn supports some of our staff. But we need more mental health workers, and as I mentioned specifically, mental health nurses, trained mental health nurses.
Who funds the other mental health nurses that are on presumably some of the shifts, but not all of them?
We don't have any nurses on. We have a St. Elizabeth nurse that comes in and does blood pressure and things like that. The Lynn funds are mental health housing workers, and the city funds the drop-in workers. We do get some funding from United Way, and we do about $500,000 a year of fundraising.
And the city funded you for how many, for what capacity?
When we applied to be a low barrier shelter, we anticipated getting 20 or 30 people. So that was what the funding was for. And we now have a minimum of 50 people staying overnight, and we serve several hundred people during the day and evening. We serve about 100 breakfasts, 350 to 450 lunches, and about 100 dinners, and soup and sandwich for the people coming in overnight.
So when you approached the city about running the program, it was 20 to 30, but was that for overnight, or was
Yes.
that? Okay. But you're really more like 50 to 60.
That's
Okay.
correct.
Thank you.
Thank you very much. Seeing no other questions, we'll just say thank you very much for your presentation and the good work that you do in our community. We'll go to questions of staff. Again, I do want to focus, our focus here is not the state of the shelter system, though we have staff here that can answer that, so we can have some latitude in the questions that we ask. Our focus really is on the count, the death of homeless folks, and whether we're doing that appropriately, methodologically, I guess, appropriately, and then that will inform shelter housing and supports work, but it's not doing shelter housing and supports work. So questions of staff. Councillor Layton, Councillor Cressy, Councillor Doucette, Trustee Glover.
Thank you very much. Presumably, one of the causes of homelessness is mental health and access to the barrier that is to access to shelters. Do we know what that is? What kind of factor that is?
So through the chair, you mean to what extent mental health is
Yes.
the rationale behind that? I don't know that we actually have those data. I think there are some data with respect, and there's a general understanding that there are mental health issues faced by those who are homeless and underhoused in our communities, but to what extent, what degree, I don't think there's actually a very good measure of that anywhere.
So Patricia's brought up an interesting point here in that if we don't have the wraparound services in our shelter, health services in our shelters, I'm trying to stick it to the Board of Health relevance. If we don't have those within our shelters, we may be in fact being negligent of our responsibility to the health, in this case mental health, of the people that are staying, that are even getting access to shelter.
So if I can, while I would agree that there are challenges with respect to provision of adequate health care services, including mental health care, those are indeed health care services, which is quite different from what's under the purview of the Board of Health. So it's the LHINs, the local health integration networks, who are actually responsible for health care service provision, and I would argue that that does absolutely include mental health care as well.
So if we were looking for resources to provide health care services within our shelter system for any number of reasons, for the health of those using the shelters, or simply to prevent emergency room visits, you would say that that's probably not the city's responsibility. In fact, we should be knocking on the door of the province to ensure that we provide those services.
And again, the province has devolved its responsibility with respect to healthcare service planning to local health integration networks. And there are 5 that currently cover the area that's encompassed by the City of Toronto.
Okay, thank you.
Thanks. So I have a few questions for the MOH and then a few for SSHA. So just so that I understand your presentation clearly, your contention is that the 70 deaths that we have identified in the first 3 quarters of this year is a demonstration of the number of deaths, but not an exhaustive list.
That's correct.
So that the likelihood is that it is higher.
Yes.
Okay. Now, you mentioned that a number of the deaths between June and September took place indoors. Do we have a sense, 46 deaths indoors, or of the 70 deaths, 46 of them have been indoors, 4 outdoors and 20 unknown?
That's correct.
Where would those 46 be taking place? Do you have a general sense? Is that in city facilities? Where is that?
So largely within the context of inner city hospitals and occasionally in our shelters as well.
Okay. And I recognize that you mentioned that there are a number of cases within the coroner's office, but do we know what the cause of these deaths are? Any of them?
So with the ones that are from the coroner's office, you get a more definitive cause of death, and then the ones that do not go to coroner's cases, one of the questions that we ask the reporters, which we call sentinels, we ask our sentinel reporters, what is the cause of death? So they also provide what they believe is the cause of death for those that do not go to coroner's cases.
So of the 70 deaths, what is the predominant cause of death that we're aware of?
So at this period of time, we know that a number of them are associated with overdoses, But for the vast majority, you have single causes, each one slightly different. And that's the challenge when you're still relatively early in an initiative and you're collecting data. You'll get one caused by heart disease, one caused by infection. So you'll get a lot of one-off causes. But if there is a group, it's with respect to a drug overdose.
Okay. Now, this is a question I'll begin with you, and perhaps I'll also with you as a medical officer of health, and then to our Shelter Support and Housing Administration team. I wanted to pick up on what Councillor Layton was asking about frontline healthcare support. My understanding from your answer was that frontline healthcare services are funded by the LHIN. My understanding was, do we not have frontline staff through SSHA that provide mental health supports and other services? I remember there was a big debate last year, I recall, on this at the budget.
So, through the chair, so primarily the provision of healthcare, including mental health services, is provided through the LHIN. And we partner with the LHIN, and we're always trying to improve that service. Right now, just as a single example, when we look at Seton House, we have the inner city health team in there. We have many different services in there that are funded through the Ministry of Health, and we're trying to expand those services more broadly throughout the shelter system so that we can have the same types of services in other shelters. But generally, the city doesn't provide broadly healthcare services. The province and the LHINs provide those services.
But we provide some, if I understand.
We have some historical nursing staff, but we certainly don't take on, we're trying not to take on the healthcare services that the province should be providing.
So is there a request in right now for additional support then from the LHIN and the province for additional services? I mean, there's a question related to beds and access to beds that we've heard and you're aware of, but the specific piece as it relates to frontline health services, because homelessness is complex in terms of what leads you to that point. Is there a request into the province for additional services? Are we looking at, through the upcoming budget, the provision of additional services via the city?
So in the upcoming budget, we are not looking for health services within the city. We are working with the LHIN currently, talking to them about additional healthcare services for the shelter system.
And do we have a sense in terms of when we expect to hear back from the LHIN?
It is an ongoing table, so I don't have a deadline on that particular piece.
Do you have council direction on that? Would it be helpful in your as you're having those conversations with the LHIN to have a council request to the ministry as opposed to just to the LHIN, because there's more than one LHIN?
So the LHIN is absolutely a willing partner with us right now. We're not receiving any sort of pushback or the suggestion that they're not prepared to work with us on this.
Okay, that's my time is up. I'm just hopeful if somebody else is asking questions that they'll ask about the number of beds. Thank you.
Thank you. Councillor Doucette.
Thank you very much, Mr. Chair. So the data we have now is a long way from where we were, but it's not where we need to get to. How are we reaching out to the other agencies which we're dealing with, which is many of them, to give them a template of what the information we need back from them? I guess that would include emergency units as well.
So through the chair, the reporting method is online, so there's actually an online form that's available to social service agencies who are participating in the initiative, which they can then fill out. And we ask for whatever information they know of, and whatever they can provide is of help to us. With respect to reaching out to other health and social service agencies and recruiting more participants as data collectors for part of this initiative, the real geniuses behind that work are right in front of you there. We have wonderful staff at Toronto Public Health who are extremely well connected to the health and social service agency community and have worked very, very hard over the years to alert health and social service agency partners of the initiative, and they in turn use their networks. So we will take the reports from whoever is willing to provide them. And of course, we have to check them and make sure that we're not getting duplicate reports, which does happen from time to time.
That was actually part of my next question. So we may get 2 or 3 reports on the same person who has passed away because they've connected with various agencies.
That's right.
So is that part of why we can't get our data out as quickly as we'd like, because you're having to review, so we make sure we don't double, triple the numbers?
That's correct.
Okay.
Right, making sure that we're actually reporting as accurate information as we can. We expect that it may not be perfect. Even with the checking, there is always the possibility of error, but we try to minimize that to the extent that we can.
So just moving on to some of the numbers, we've got 46 people indoors, 4 outdoors. As we move forward, are we going to be able to break this down more into the cause of death of these people as well?
Yes, that's the expectation, is that as we get more data and as the initiative carries on further, we get better and better data so that we can then report and provide that information, as the chair pointed out, to the various partners, whether they're city partners or other partners within the community who provide services to the homeless population, so that they can then use those data to inform their programs and services. And that would include our provincial healthcare partners as well. They would certainly benefit, I would expect, from having those data so that they understand what are the mental health services that are needed, where are the gaps.
So you mentioned that a certain number of these deaths are related to overdose.
Indeed.
So as the years go on, we can see if that number's going up or down, or, as you say, other reasons.
That's correct.
And this is just early stages, right? So when did we actually start doing this kind of programming?
January 1st of this year.
Okay, so really, really is new. Okay, thank you.
Okay, it's been an interesting discussion. I'm still trying to wrap my head around some of the data we've got. So on the page here that says whether people died indoors, outdoors, or unknown, what is unknown?
That we actually don't know, we don't have a report with respect to where they
passed away?
Where the death occurred, yes.
Okay, but I'm assuming then who's, like, what's the circumstance around that you know somebody died, but you don't know where they died? So it's like, is the ambulance bringing somebody who's passed away to the hospital, and that's where it's reported and that's where it's found?
So there are all sorts of circumstances, and our staff may be able to give you more of a detailed sense, but just by way of reminder, these death reports are provided through an online form, and anybody who's aware of this method of reporting is able to go online and fill in the data such as they know them. So, for example, I may know of somebody peripherally who I've heard has died and who I know to be homeless, but I may not know the exact circumstances of death, but that shouldn't preclude that individual from saying, I heard that so-and-so died, here is the name, I believe it happened on this date, but I don't really know where, and I don't know what the exact circumstances were.
Okay.
So because of the nature of the reporting system, because we're actually allowing for a wide variety of sentinels to provide us with information, we get varying levels of information.
Okay. And you mentioned in your presentation risk factors. What other risk factors are you collecting information on?
So we have a whole slew
There's
of
a whole slew, and there's a list on
We're
that
trying
survey?
to anyway.
Yeah?
I guess that's the
Okay.
issue. The question is, do we have enough that actually tells us something that's meaningful? So for example, when we talk about location of death, you've got the data in front of you, but because the numbers are still, and the initiative is still relatively new, we're still growing and understanding what we're able to collect, we can't actually make meaningful comparisons.
Okay.
I do think that there are better data, and I know that there are better data in respect of those cases that actually go to the coroners because they're unexpected or because there's a suspicious circumstance around that death. In those circumstances, because of the nature of the coroner's investigation, we actually get more detailed information. But that's only for a subset of those deaths that are involved in this.
Is there any qualitative data that's collected with this?
For example,
for example, the deputant was telling us a little bit about some of the people who had passed away at Sistering.
right.
And I mean, personally, I find that very informative. I'm assuming that the goal here is not to provide better homeless services, but to actually provide information that will allow us to make a case to provide housing so people aren't homeless. And I'm thinking that, some of that case is much stronger if instead of knowing these people as numbers, if we actually know a little bit about who they are and what their struggles were so that we can understand better how to address them.
Absolutely. So through the chair, I don't think it's an either-or proposition. I do believe that it's, one, a little bit about providing better services for those who find themselves homeless or underhoused, and also to try to get to root causes of homelessness so we can try and prevent those circumstances from happening in the first place, and also to move people successfully out of homelessness back into a more stable housing situation. So we do seek through our online form to get more information. So we ask about, what do you know about the health circumstances, or what pre-existing conditions might have occurred for that individual whose death you're now reporting. So that's in the online form. What do you know about them? What do you know about their circumstances? There is that an opportunity to provide those data, and our Sentinel reporters provide us what they can provide.
Okay, so there is a section where they can just make comments, and they
There's a
just write a
comment
description.
section. Yes, there is.
Okay. And is that data available publicly, or is that private data because of the
So again, at this stage of the game, we have relatively small numbers, and these are still very much personal health information. So if we were to put those data out right now, you may actually identify the individual. So that's, the question is, how do we provide the appropriate balance? We want to make sure the data are useful and used by those who can actually make decisions, whether we're talking about healthcare, homelessness services, and/or homelessness prevention. But by the same token, we want to make sure that we're doing so in a method that preserves the confidentiality and the privacy of those individuals. So this early on in the game, because there are 70 who are counted in this database right now, it's a little too identifiable. Things start to change as the initiative has a little bit more time.
So there you go, it will be public, and it'll be on our open data sets.
Again, pending,
At the appropriate
making
time.
sure that we're able to preserve privacy. We want to make sure that the data are available to those who can actually use them in terms of decision-making, while at the same time ensuring that we're preserving the privacy of those who are part of this data set.
Thank you. Councillor Fletcher.
Thank you. I may have missed it. I'm just interested in the percentage increase since we've added these other partners in the collection.
The percentage increase with respect to deaths reported. So if I remember correctly, last year, we knew through the shelter system of the deaths of 24 homeless individuals, and this year we now have 70.
So the percentage is considerable.
Is that right?
It's 200%. Almost 200%.
Or sorry, we would have had 24 reported this year if we actually only used, that's what it is. We would have had 24 deaths reported this year had we used the system of just those who are associated with city-funded shelters. And now we actually have 70 in total. So we know that we're getting more by actually allowing for and creating a system for others to provide the reports. Sorry, and I'm just going to turn to staff if we know what last year's numbers were.
I think that's better to.
So through the
it's fine,
chair, if I
actually.
can help out with that.
I'm fine with that answer because we're comparing apples to apples, which is 24 if we only used our previous way of counting, and now it's 70. So
Sorry, Mr. Chair, if I can correct that. So this year to date, we would have known of 24 deaths amongst homeless individuals if we had only relied on the data through, yes, exactly.
So 24 if we
Correct.
used our old way, and 70 now, so it's close to a 200% increase in understanding how many people who've died homeless. So thank you. And then the sources, obviously, are shelters. Could you just describe a little more fine detail? The other, is it just emergency rooms? Are there other shelters? Who are those other 46 people? Where are they being reported?
Oh, so we have over 200 health and social service agencies, various community agencies who are aware of this initiative and can report.
So are you able to tell us what sector they're in? Are they in the shelter sector? Are they in the health center sector where that's coming from?
I think all of the above.
So there's 40, when you report out more fine detail, you'll be able to say exactly who they were?
Who did the reporting?
Correct.
On each individual, I think we can talk about those who are participating in the
That's what I'm
initiative.
talking about.
Yes,
Who
but it's over
participated?
200 agencies.
Who participated in identifying the additional 46 people? Was it St. Mike's? Was it, that's what I'm interested just in knowing.
Okay, so I'm going to turn that over to the staff.
If I can, it's a variety of social service agencies. It's drop-in centers where a lot of homeless people spend most of their days. It's health services. It's not the emergency rooms, though. It's not the hospitals at this stage.
So you could tell us who that is when you report at the end of the year. Here are the people that have.
I don't know that we're going to say these are the particular shelters or agencies that reported because, again, confidentiality.
But you
is
could say
involved
there
with
was 10 drop-in centers. You could say there was 5 shelters that weren't city shelters. You could make categories and
That's
let
right.
us know very
For sure.
clearly where this increase of information came from.
That's right.
That would be helpful, so I probably would ask for that
Yeah.
when we get the next report, so we know who has really stepped up and is giving us that type of information. And then when we're talking about the LHINs, we talked about the LHIN earlier, but we have shelters that are covered by other LHINs. So another, the Kennedy Shelter for Women, that is not the Toronto Centre LHINs. That's going to be a LHINs that perhaps even is associated with Peterborough or some cities and towns that are much further away. How do we deal with those LHINs when we're talking about the types of services that are required?
Yeah, so through the chair, great question. It is a challenge having the 5 LHINs. So there's 2 ways that we're doing that. Susan Fitzpatrick, who is the CEO of the Toronto Central LHIN, is leading the charge on a number of initiatives representing the LHINs. But also we have a 5 LHIN City of Toronto table where we bring these things up. There's representatives from all 5 LHINs at that table.
Just something to dig down for a second. You didn't put my time on there, Mr. Chair.
I
really
forgot it, and you're
appreciate
too
that.
well
I've got
into
quite
it.
a few more minutes. Get ready. I've got 5.
no.
Is that 0?
Don't push too hard.
Just interested in the method. So if there's somebody at the Toronto Centre LHINs, and I'd say the majority of shelters fall within the boundaries of the Toronto Central, is that person able to kind of be the advocate and work with the other LHINs as far as getting them involved in funding and assisting for services in these shelters that lie outside the boundaries of Toronto Central?
So I want to be careful not to speak for the LHINs, but I would say that working with Susan, it's been quite positive in terms of crossing boundaries.
Because I note here from the Toronto District School Board, and I'm sure that Trustee Glover will speak a little bit more about it, but the difficulties that they are having in trying to deal with students and their health, and we're dealing with homeless people and their health over 5 LHINs. And of course, even in our situation, most of those LHINs don't have a lot of shelters in them. Would you agree with that? This is not something that
agree
you're
with
that familiar with.
Yes, I would agree with that.
And I'll just ask the MOH, have we reached out to the Minister of Health with this situation where we have 4 other LHINs that may have, maybe the Runnymede shelter might be in one of those LHINs when it opens up, but that they're very unfamiliar with shelters, the needs around shelters, the funding required around shelters, and therefore would really require an extra special effort as far as meeting and addressing the needs of those who are in those shelters. What steps have you taken or do you plan to take with the minister?
Well, I think we can, I don't know that we have a special avenue to the minister per se, but we certainly do have opportunities to discuss with our partners in the Population and Public Health Division. When we're talking about specific health care services, our best venue is actually through the LHINs. They're the people that we actually meet with more regularly, and they're the ones in charge of the local level of planning of healthcare services. I expect that they in turn would be able to connect with their partners at the provincial level. But as a public health practitioner and as the head of one of the local public health units, we don't deal in general with those at the province who actually provide health care services.
Although I think we have in the past, Board of Health can also make recommendations to have a lead LHINs or have a lead in order to make sure that LHINs are carving out funds in other areas for homeless. Thank you.
Thank you. I just
Look at
have,
that, I still at 0. It's fantastic.
you were very quick there, very quick. So I'll put a timer on for me, so I don't do to me what I didn't do for Paula. Councillor Fletcher. Just focusing on the numbers themselves, because there's been a lot of conversation in social media and in letters to my office, and I think to your office as well, how often we're going to be presenting this data. I have a motion here. If I remember correctly, we're going to be presenting it to this board once a year based on a year's collection of data. Is that accurate?
Yes, that's correct.
And then in terms of live data, whereas before it took us, people may be aware that it took us 2-3 years to get to get the data collected and presented to the public. Now we have data as of the end of September, so we're much better at getting the data. Is that accurate as well?
That is correct. So what's happening is that since we started this initiative, we have been reporting the data on a quarterly basis publicly.
And that data, as it becomes high enough that we don't violate any privacy concerns, that will be posted online almost as it becomes available, no longer than 3 months. Is that fair to say?
So I think the goal here, and perhaps what's the better way to characterize that, if I may, is that we will try to provide the information in as timely a fashion as possible, in as complete a fashion as possible, while at the same time making sure that we're maintaining the privacy and confidentiality of the individuals.
Okay, so we've made great strides in being more contemporaneous in the provision of data. We'll be as good as for example, the BC, British Columbia cities are in providing the data.
Once we have, again,
With
we're
that
trying to
caveat.
balance out timeliness and comprehensiveness with ensuring the confidentiality and privacy of the individuals whose data are posted.
Great. So now, my last question is actually to Paul Raftis, the head of Shelter Housing and Support. I know it's early. I can't see anything that this necessarily tells us that we should be doing differently, more of. Is there any insight of how this might actually have an impact on the work that you do? Are you seeing anything at this early stage, which is only 3/4 of 1 year away from the council motion asking public health to do this work?
Yeah. So first of all, it's a great initiative. I'm really happy that we're starting to count the numbers. The numbers are very small in terms of a data set to be able to glean information from that. Coming from EMS, we would look at 300,000 cases in a year, and then be able to split those out. So I guess from my perspective, what the most important piece is that we're collecting them. We have a better relationship. Working with Toronto Public Health to work together to look at those opportunities for preventable deaths. And as the data becomes more fulsome and starts to maybe provide those opportunities, we'll be able to change gears and help with that particular piece. We do know outside of the data that we need to provide additional services, and we have been through council approved, been adding additional services, especially this year. And on Friday, we announced our 5 winter respite sites to open up 250 low barrier spaces, longer than ever before, from November 15th until April 15th. And also we have added more shelter space, and we're going to continue to add more shelter space next year. And also you have approved our response to the increased number of refugees coming into the city with many more spaces for them also. So the organization is working exceptionally hard to make sure that services are available. Toronto provides more service than any other community per capita in Canada, and 3 times that of Vancouver. But that being said, we need to continue to provide more. We know that the need is growing, and we're going to continue to do that.
Great, thank you very much. Okay, seeing no further questions to speak. Councillor Cressy, and then Councillor Fletcher, then myself.
Well, thank you, Chair, and let me begin by thanking our staff in Toronto Public Health who, following our motion, which was just last year that Councillor Ainsley and myself moved, have moved quickly to access this data. Though I must say that the data comes far too long. And in doing so, I want to thank, not since we first requested, but as a city. And in doing so, I want to recognize and thank all the activists from the Homeless Memorial Project who have been on their own seeking to track this data for decades. I think what we've heard here today very clearly is that the number of deaths are even higher than we had thought. And with 70 deaths already this year, 1.8 deaths per week, what we've heard is that this list that we're aware of is likely a demonstration of the scale of the crisis, but not an exhaustive one, that it is likely very much higher. And so it just, 70 deaths in a city as wealthy as ours is an absolute failure on the part of everyone. At the political level, absolutely. And so I just don't think we can claim to be the world's most livable city as 70 people die in our streets. And so I think this data collection today is not where we're going into the comprehensive response, but rather an update on the stats. I think this demonstrates to us the scale of the crisis, and certainly as we prepare for this winter season, and our staff who are doing tremendous work and working night in and night out in shelter support and housing administration to ensure that we have enough beds. We know we need far more. But I also think we've heard very clearly, certainly last year during the budget process and here today through a deputation, that more than just beds, because homelessness is complex and thus the solutions must also be complex, those frontline health supports need to be increased at the staffing level. And certainly at the next CDRC meeting, as it relates to whether it's working with the province, requests of the province, or through the city directly, that's something that I'll be looking to talk about. Thank you.
Thank you, Councillor Fletcher.
Thank you. Also mirror the remarks by Councillor Cressy, and just as well thank SSHA and Shelter and Housing Support for all the work they do in our shelters, and all of our partners in the community that work so hard and do so much for those who are homeless. I do hope that our full year report, when we get that, we'll be able to aggregate, again, take the full year that would have been through our shelters and then add on, not by name, but by type of service, who has been helping. So we know if it's drop-ins, we know where that information is coming from. That would be very, very helpful. I also think it would be helpful in that report to really have a clear understanding or clear look at whether or not, or quite possibly has, not whether or not, but how the opioid crisis has affected the number of homeless people who are dying. And if it's significant, which we could look at our last year, we know it would be 24 if we were counting just ourselves. Would that have been the same number the year before? But do we think that that is having a significant impact because we believe it's having an impact in general in society? So looking at the nature of these tragic deaths, and to look and say possibly by the end of the year we'll be up to 2 people dying a year that are homeless, and that is just a terrible tragedy in the city. So it is obviously not something that we want to continue. I think once we have sources and we know where people are and starting from, if they're not in our shelters, that is a type of outreach that can begin, and if it's not underway, a little more can begin in a more targeted, cohesive way. And again, once we have that information, back to the LHINs. And I'm very, very clear that we have the Toronto Central lens, and we have so many of the folks that are homeless are under that lens. But as we're expanding the shelter systems throughout the city, we need to have very, very strong relationships with all of the lens, the other 4 that cup all the other areas of the city that are going to have the shelters. And I would be sure that the Runnymede shelter is not within the Toronto Central lens, although Councillor Doucette could correct me. I know the Kennedy shelter, the newly opened one for women, is not in the Toronto Central lens, and there's probably a number of others. So that'd be also helpful for us to know as well, and political representatives to know which lens could be more helpful as far as establishing shelters. Because when we are establishing shelters, having the lens very clearly on board to provide services is actually a critical piece of ensuring a well-run, well-resourced shelter for the people that find themselves staying there for whatever period of time. Thank you.
Thank you, Councillor Fletcher. Just add some final comments in the motion. The motion that I have is ask the clerks to put before you. And basically, it is to ask her to report back by March 31st of 2018 to do the year-end data collection for 2017, to report back no later than March 31st, 2018. Then we'll have 1 year of data for the purposes of this exercise. You know, I do remember the day, I think it was in the maybe late 1980s when someone died, a homeless person died on the streets of Toronto. And it was a news story that lasted for, frankly, almost a week, maybe even longer. And it was just so abhorrent that the city of Toronto could allow someone to die homeless. Now it's 2 a week, almost 2 a week. And so I hope that this isn't a trend that says we are becoming callous to the reality of people dying in our streets. America tolerates this way more than we have historically, and we can't go in that direction here in this city. I think it's, my last point is, and just by the way, with this particular motion here, this is just the piece that gets reported in a printed copy for the Board of Health's edification once a year. It'll be something like this, the winter of the year, speaking to the data from the previous year. That isn't to say that people who are into open data or people who are monitoring homelessness and deaths related to homelessness a lot more closely won't get up-to-date data as it becomes available. I think that is all good, and that fulfills actually the direction of that motion that Council had in April of 2016. So having said all that, I think it's like at the end of the day, why do you collect data? Why do you do it? You do it to inform policy and to inform action. I don't think at this point we should make too much of it because, you know what, the data set is too small. Like, I think you're looking for trends and patterns and wheres, and is it opioid related or is it not opioid related? And that informs then the work that Paul Raftis and his group does in another division. So this is just the first set. There's going to be a lot more coming in the years to follow. Hopefully, the numbers will go down this way, and that will be a sign that we're indeed becoming Toronto the good, the better. But for now, it's a little bit too early, it seems to me, for us to be making any big conclusions around policy direction. Okay. So there's only this motion on the floor to get an end-of-year report by March 31st. Can we vote on that? All in favor? Opposed, if any? That carries. That's basically it for that item. Thank you very much to everyone for presenting, Patricia O'Connell in particular. Okay, we're on to 22.2, which is the Minister's Expert Report on Public Health in an Integrated Health System. There is no presentation. We do have two deputants. Gil Penalosa, founder and chair, 8-80 Cities, and Monica Turner, Director of Policy, Association of Municipalities of Ontario. And Gil, I understand I see that you're also on the next item and you want to depute on both of them. So with the board's support, we'll give you 10 minutes to go to both.
Oh, excellent. Thank you. I think that it's very clear that there is no health system in the world that could survive if it's just curative. We need a health system that is...
Just a sec. Joe, take it outside. Sorry about that.
So I was saying that there is no health system that will survive if it's only curative. We got to have a health system that is preventive. And I'm worried how the provincial government is moving forward. Just a few years ago, 3 or 4 years ago, we used to have a Ministry of Health Prevention, Health Promotion. And it was absorbed by the gigantic Ministry of Health. The other one was small, but at least everybody, every single person was focused on promoting health, how we live. Now it's a tiny office in the middle of this gigantic that is focused on curative, on urgencies, the hospital, the medicine, and so on. And it's clear this is not as effective. And now that it's suggesting to split the health system in Toronto, public health, and not only Toronto, but all across the province, and absorb this, I think it's going to be a huge problem. First, I think that it's important that Toronto has a public health for the city. Health promotion has to do with how we live. Just to give you an example, in the last 30 days, I have worked in more than 13 different cities in 6 different countries. And all of this is related to health. I've been working in London at the Royal College of Physicians. I've been working in Birmingham related to sport and culture for all. In Amsterdam, issues related to placemaking, how to create places that are vibrant and exciting. In Copenhagen, I took 30 cities leaders from the US, including public health, planning, transportation, to Copenhagen for 4 days. I was in Ghent in sustainable mobility. Yesterday, I was in Argentina working on issues on happy cities. Tonight, I'm off to Orlando to work on with the mayor of Orlando and all of the commissioners on creating a healthy city. Why am I saying this? Because that's what public health is about. 100 years ago, we were dying because there was no clean water and sewage and lack of vaccination, but now we are dying of life-related issues. And we need public health working with all the city departments. We need public health working with Parks Department to make sure that every single child and person in Toronto has a park or a play area within a 10-minute walk. We need public health to be working with transportation so that we know that sustainable mobility is an actual option for everyone. We need public health to be working with planning so that we are facing a huge urgency. We're going to grow by more than 50% population within the next 25 or 30 years. The GTHA is probably the fastest growing area in the developed world in the next 30 years. So public health has to really be front and center in how we grow, how dense, how's it going to be the mobility. Issues such as loneliness. With our population over 65 are going to double. The population over 80 are going to quadruple. A lot of the issues of the older adults have to do, the 2 main issues are mobility and isolation. And a lot of this about public health prevention. I think that splitting health in Toronto in 3, which is what would happen. The East also engaged with Oshawa and others. The center engaged also with Simcoe. On the west side, with Kitchener and Waterloo. A lot of these municipalities don't really have the same issues as Toronto has. At the same time, within Toronto, having 3 different offices, trying to work with the different departments of the city, it would be totally inefficient and expensive and not productive. So I think that it's important that the city will make a strong case to the province that we need to have public health as one in the city, working with all of the city departments in this crucial time. In the point of view of the traffic-related air pollution, I think that more than electric cars or more than having driverless cars or anything, we need to work on sustainable mobility. We need a city where people could walk, could ride bicycles, could take public transit, and in a safe manner. Obviously, we're going to move eventually to automated cars, but when we have driverless cars, actually we're going to have many, many, many more cars moving. We're going to have less cars parked because maybe people will not have their own cars, but we're going to have many more cars moving. So how is this going to affect our city? We cannot just accept this technology blindly, because the older people that are not driving any longer, well, if they are driverless, they're going to have their cars till they die. Maybe you don't have to be 16 to drive a car, so you might not even have to have people to have a driverless car. You can also have people-less cars. You come here, you don't have parking, you tell it to go home and come back and pick you up. So we might have many more cars. So I do think that council should focus on changing behaviors, on changing how we live. And I think that we need to put money into it. We just approved Transform TO, where we said that we are going to eliminate 80% of the CO2 by 2050 without 1 cent. It doesn't make any sense to approve policies without money. It's worse than nothing, because the citizens get the idea that we are moving forward, so they say, oh, check, let's not worry about that, because no. Same thing with Vision Zero. We approved Vision Zero, and we don't really put any money that will make any difference in Vision Zero. You know, a person walking in Toronto gets hit by a car every 3.5 hours. A person riding a bicycle gets hit by a car every 7 hours. And then we have a bike plan. 10-year bike plan where we're putting $16 million per year. That's laughable. $16 million when we have a budget of $13 billion. We need to do much better than that. So I substantially encourage that we need to make walking safe for all ages. I run an organization that is called 880 Cities. 880 Cities is a simple but powerful concept. What if everything we did in our city, the crosswalk, the sidewalk, the bikeway, the park, the library, the building, everything had to be safe for an 8-year-old and for an 80-year-old? Because not 8 to 80, but 8 and 80 as an indicator species. Because if it's good for the 8 and it's good for the 80, it's going to be good for everybody from 0 to over 100. And we really need to create a city that is safe for everyone. And currently, it is not safe to walk. It's even less safe to ride a bicycle. And public transit, we're not creating a grid. And we are really wasting a lot of resources. There is no city in the developed world that is building elevated highways, and all of a sudden we're going to move the Gardiner and build an elevated highway and waste $2 billion in that. And they say, we don't have money. Well, we could save those $2 billion if we don't tear it down and build it. It sounds nice because we call it hybrid. But hybrid is the worst of both options that we had. And then we go to the east side and the Scarborough subway. We're going to leave 80% of the people in Scarborough without subway, without public transit. They're going to have only one station, so 20% of the people in Scarborough, and we're going to waste $4 billion. That's $1,200 per citizen, $1,200 per man, woman, and child. And we just heard the issue of homelessness. How can we be having homeless people dying when we're going to spend $1,200 per person on a subway, on a one-stop subway? So I would say that the issue of the pollution is an issue of changing our behavior, of changing how we live, and to really promote walking, riding bicycles, using public transit in a safe manner. We need to be more consistency between what we think, what we say, and what we do. Thank you.
Thank you very much, Gil. Are there any questions? I have one. You spoke on, it's very interesting, you spoke on two topics. One is the reform that is being proposed at the provincial level of the public health within an integrated to what? Health system. And the second issue that you spoke on was reducing health risks of traffic-related air pollution. Would you say that the second issue is an example of why the first issue should not happen?
Exactly. We need to work totally integrated. everybody in the city, because if we have parks or not have parks within walking distance, that's what some of the issues that we're going to have to deal with with how we do the parks. We just approved the ravine strategy. That really has to do with health. There are very few access into the ravine. So both are totally the parks. Last week, the mayor of New York approved that Prospect Park, that is similar to our Hyde Park, they will not have any cars going through Prospect Park as of January 1st. Why are we being suffocated in Hyde Park through cars going up and down all the time, which makes it dangerous and also pollutes the quality of the air, when we have really fantastic public transit going into Hyde Park? We got subways, we got streetcars, we got buses. So those are the things. The two are totally interlinked.
Great. Just the last one on the 22.3, the air pollution. There's so much media conversation on electric vehicles and self-driving cars. As a city planner, is that a 2% of the solution? People are saying that's going to end our environmental woes related to traffic and congestion.
Well, first,
what would your views be on that?
Most people are concerned about traffic jams. Well, the traffic jams are not going to stop because the cars are driverless or driver. I think two effects are going to have the driverless cars. One good one, we're going to need less parking because the car ownership is going to be reduced, so that's going to be good. And also they are cheaper. So since it's going to be cheaper, and it's going to be less park, we're going to have many, many more cars moving. That means that congestion is going to be worse, that if we don't use electric or somewhere, that they might be even more polluting, and also that more people are going to sprawl because they say, oh, now I'm going to have a car, so even if I age, it doesn't matter, I can use. So we need to, instead of doing what we did 100 years ago to say the car is coming up, maybe we should have done a second network, one for the cars, one for people walking and cycling. Now we need to rethink, how are we going to use those cars? Sometimes we're really happy that, oh, now we're going to have space for bicycle lanes. Well, what if the manufacturers of driverless cars say, oh no, we have many more cars moving, so we need more space. So the space from the cars park, we needed is to move cars. So I think that we need to anticipate, because otherwise that's going to be worse. I think the reality is that we need public transit, and a major part of Toronto, big sectors of Toronto, we do not have public transit. And we will not have if we spend $4 billion in a one-stop subway and the $2 billion moving the Gardiner, which we could, instead of that, have a network of public transit through light rail to LRTs and BRTs across the city, and have everybody within access to public transit in an efficient that is fast, is safe, and clean. So the quality of the air would be much better for everyone.
Great, thank you very much. Any other questions? Thank you, Gil. Appreciate your time with us, as always. Next is this is for the expert panel on public health in an integrated health system. Monica Turner, Director of Policy, AMO, Association of Municipalities of Ontario. Welcome.
Thank you very much. And thank you for the opportunity of speaking to you today. I'm here to talk to you about what other municipal leaders are saying, what other municipal organizations are saying about the experts panel's recommendations to integrate public health with the healthcare system. To date, and to start, we haven't heard any municipal leader or a municipal organization saying that this is a really good idea. In fact, we're hearing the opposite. We're hearing that it doesn't make sense and it's not a good idea. And just to go over some of the things that are being said, the first one, if the expert panel recommendations are implemented, it will completely change the public health system and place it within the healthcare system. And you had a conversation about that earlier today. It's like the elephant and the mouse. Public health would not be able to retain its identity and mandate if integrated. The needs in the healthcare system are too strong, and there's evidence across the world where when they have been placed closer together, there's somewhat of a vortex that happens. The public health system is focused on population health and health promotion, prevention, It works upstream on social determinants of health, which is not a focus of the healthcare system, which focuses on individual health when sick or injured. There's not been, and I need to say, the expert panel was not instructed to talk about implementation, but there also was no analysis provided as the recommendations were done. There was not any analysis cost-benefit from a patient or program perspective. So what I'm saying is there's great concern that public health would lose its local focus, and with it, its strong municipal and community integration. Public health, especially for regions and single-tier municipalities, are fully integrated into the municipal system with respect to governance as municipal employees, fully engaged in the full spectrum of municipal services such as planning, transit, housing, social services, even crime prevention. We don't want this lost if public health moves into health. We're also very concerned about the potential loss of the local voice in governing and directing public health programs and services to understand and meet the diverse needs of our communities. And buried very deep in the panel's report was the suggestion that key positions of the proposed regional boards, the chair, the vice chair, chairs of finance and audit committees, should be limited to the provincial order and council appointees to ensure accountability to the provincial government. So I will say this goes to the potential trend we are seeing from the province to weaken local elected members on local boards, and I will point you to Bill 139 on conservation authorities as an example of that. And as well, the Health Protection and Promotion Act still has municipal governments legislatively responsible for 100% of the costs of public health, although by policy the province is now saying that they will fund 75%. But that is policy, not legislation. And one of the concerns with the expert panel's reports is that municipal governments will be less inclined to top up funding or contribute other in-kind municipal resources, which greatly benefits local public health. We did a quick analysis using the FIRs of the Ministry of Municipal Affairs. In 2015, the last year data is available, municipal governments funded 38% on average of the public health costs for mandatory programs, Ontario Public Health Standards. That's on average. Now, we also know that many municipalities have to stay to 25%, so that means a number of municipal governments are funding well over 40%. It's also suggested, and this won't be a surprise, that the more the province moves towards regionalizing public health and further from the municipal core, the more the province should be responsible for the funding of it. And so one of the questions that I've heard a lot from municipal leaders is what exact problems was the expert panel trying to address, because there are ways to improve LIN planning and deal with public health capacity without the province blowing up the entire public health system to integrate it with the healthcare system. So that's an overview of what we've heard. The deadline, as you know, for providing comments to the province is tomorrow, Halloween. And I will say that I know that municipal governments across Ontario are sending their comments in. Thank you.
Thank you very much. Appreciate your comments. Any questions? Okay, sorry. Go ahead, Trustee Glover, then myself.
Just a quick one. So what's the province's response? Because this board and also the Toronto School Board had the same response as your municipal leaders. So what's the response from the province on this?
They haven't responded to my knowledge, and I think in some ways they were very strategic by just putting out the expert panel recommendations without commentary, though some analysis would have been nice. So it actually allowed for a full consultation. They also extended the consultation period till the end of October with respect to how long it would take for municipal councils to be able to consider it. So I think they're sincerely wanting to know what people think, and that's to be credited. So we're not sure what they're going to do once they get the analysis. I think they're going to it's going to take some time to get through it all.
Thank you. Just a quick question. My sense is, and this, it's hard to read the tea leaves here, is that they were looking at other jurisdictions in the way many a senior order of government who has done this in the past, that they were thinking that perhaps Ontario should follow suit, not noting that the jurisdictions that have done that have found that they did find that it was an elephant sleeping with a mouse, and public health weakened its strategic municipal abilities in doing so. Do you think they're kind of trying to do a Me Too with other jurisdictions?
I can't answer that, but I can say that in other jurisdictions, at least from a public health lens, and I'm thinking particularly Nova Scotia, the UK, et cetera, that once public health and its professionals get too close to healthcare.
Primary health.
The need is so great. You want the nurses, you want the epidemiologists, you want those folks to help with health care, and it can't help but integrate. I'll also point you to Alberta, that's gone back and forth between regional, decentralized, regional, decentralized. And again, I think Ontario has been very clear about the local nature of public health, and I think that's what at least our members are talking about in this.
Great, thank you very much. Seeing no questions, well, thank you for your
Thank you.
excellent deputation. We'll take it into the board. Are there any questions to staff? Councillor Doucette.
Thank you very much. I know you may be a bit biased on this report, but anyway. Toronto, I would see Toronto being unique to some of our concerns and some of our wishes for bylaws than some of the GTA area. Would that be a sort of good analysis? We look at different things than some of the GTA?
So if I can, through the chair, I think Toronto is unique, period. And I do think that we have unique circumstances that do make us different from other jurisdictions, even those immediately around us.
The other thing I don't quite understand is funding. Page 7, it says that under this model, City Council will not have a role in the public health budget process or decisions making, including determining budget growth, staffing, resource, so on and so forth. So, well, that would make our budget so much easier here, but how would budget work? Because it's not just going to be Toronto funding. I mean, personally, Ward 13 stays in the downtown central area. I'm thrilled. But what will happen if we go, we're doing funding with other regions? How does that work? Would it work percentage on bodies? Will it work who's got the loudest people? How will that work?
So through the chair, I don't know that I can actually answer that question. As it turns out, to be fair to members of the expert panel, the specific mechanics around funding and those kinds of issues, there were general principles that were provided, but the specifics of the funding were not within the purview of the expert panel. So I think at this stage of the game, we can only really look at that which was proposed by the expert panel in terms of the recommendations, and I think we're left to try and surmise what the specifics of the funding arrangements might look like. How would it mechanically work with 3 regional public health entities serving the City of Toronto and a municipal council also serving that same city? What would the negotiations look like? How would you ensure some consistency of service? I think there are a number of questions as highlighted in the report before the board, but I don't know that we can actually speak to specifics with respect to how that would actually work in practice. That wasn't considered, and it wasn't within the ask of the expert panel.
I guess simple questions like Toronto has taken on the pesticide. We did a bylaw saying you can't use pesticides in our city. We know we can't tell people around us to do the same thing, but we could get into a situation where part of a city would have a bylaw against pesticides. You walk across the other side of a street and they could use pesticide. Is that the sort of thing we could be looking at if this went ahead?
And through the chair, that is one of many things that you could be looking at should the expert panel recommendations be implemented. That inconsistency, quite literally, as you suggest, from one side of the street to the other, depending on where the regional public health entity line is.
Okay, I won't make my next comment. Thank you.
Okay, thank you. Those are any other questions on this report? Speakers? Councillor Doucette, Trustee Glover.
I'll be careful with my comments here. I don't support this committee's decisions at all. I think it's going to decimate our health system. I think it's going to make lives for our residents worse. It's one of the most ridiculous things I've heard. And as I say, I'm choosing my words carefully here. So I do support Toronto Health and this Board of Health giving good direction, saying that this wouldn't work in our city. We've heard that other municipalities are saying the same thing. I think we've got to just get together and say, I'm sorry, but as a government, you've just wasted however much money it is. Well, actually, we could have put that into helping the health of our residents rather than coming up with something like this, which, as we've heard, they don't even know how to implement it. So what a waste of time. Thank you.
Thank you. Trustee Glover.
Okay, I'll just mention it, and you've got it on your desk, but there is a letter from the Toronto District School Board. So I brought, and I want to thank the TPH staff for helping me to draft the backgrounder and the motion that went to the school board, but it basically echoed the concerns that have been raised at this table, and it was passed unanimously by everybody at the board. The only amendments were to add in all of the affected school boards that would be, partnered with us in the city, be part of the new map. So it's gone out wider. It's probably too late for those school boards to respond within the deadline, but perhaps they could respond after the deadline. But just to say that the school board is completely in line with with the thinking of the Board of Health on this issue, and that they don't want any part of this recommendation implemented.
Great, thank you. I'll just add a few more comments just to make sure that sorry, Councillor Layton.
Yes, I'll just very briefly, because if I remember correctly, the last time we met, I kind of went to task on the rationale behind sticking councillors from wards 35, 36, and 37 in with councillors or municipal officials from Halliburton. Didn't make much sense from a logistic point of view to hold regular meetings. And I think the same truth stands now, that you're going to have a really, really tough time figuring out the logistics when you have strange local bodies like this that overlap like 5 different political boundaries, and that it takes hours to drive to get to a meeting. You're just not going to have in-person meetings anymore. So.
Well, I think the heart of the opposition to this is well articulated in Amo's letter in the first 2 bullet points. Our main concerns with the expert panel recommendations is that public health will lose its local and community focus. It is currently integrated, so it's not we're seeking integration. It is already currently integrated within its communities with multiple local linkages with both public and private bodies and organizations. So we are totally integrated with the municipal system. If you look at this agenda, every piece, so we just had people from Shelter Housing and Support sitting over there. Now we have people from the Environmental Office sitting over there. And at the next item, the last items that we'll deal with on food security, we have our Toronto Food Policy Council and Urban Food Wise Owls here on that issue. This agenda would frankly disappear if we were integrated in a different way with the curative or primary health care system. So I think I just think this needs to be be very quickly done with and ask the province to basically step back from it and try to find ways to strengthen public health rather than trying to integrate them away from the municipal system and towards the curative or sick system, as some people have called it. So we have the motions in front of us. Any final comments? Seeing none, all in favor? Opposed, if any? That's carried. Okay, we'll go on to number 3, which is the reducing health risks from traffic-related air pollution in Toronto. We have a presentation, and then we have 2 deputants as well. Dr. Davila.
Thank you, Mr. Chair. In fact, the presentation will be delivered by 2 of my colleagues at Toronto Public Health. They're over at the desk there. Gail Bursey is our new Director of Healthy Public Policy, and Kate Basil is our Acting Associate Director, also from the Healthy Public Policy Directorate. So I'll turn it over to them.
Thank you. Good afternoon. Through the chair, we are pleased to bring you this report entitled Reducing the Health Risks of Transportation-Related Air Pollution. This is a joint report with the Environment and Energy Division that will also be presented November 17th to the Parks and Environment Committee, and eventually it'll go to Council. The origin of this report is that Environment and Energy were requested to report back on a city-wide study of air quality. As well, they were asked to report on the important contribution that transportation contributes to air pollution. So our role in public health is as a partner in this work. Specifically, we are reporting on the health impacts of transportation-related air pollution, and we also assisted with the development of the recommendations to mitigate these impacts in 3 ways: through policy, through engineering for our existing operations, and through education. This presentation, like the report, is divided into 2 parts. First, I'll highlight what we found in the report from a technical point of view in terms of the extent of exposure, and then Kate will walk through the recommendations that are aimed at reducing this exposure. So looking at the results of our review, we found that over the last decade, in fact, air quality has been improving in Toronto. That said, it continues to have substantial health impacts on outcomes such as cardiovascular or heart disease, or on respiratory diseases, specifically lung disease. Toronto Public Health's 2014 report, Path to Healthier Air, estimated that air pollution in general contributes to about 1,300 premature deaths and approximately 3,500 hospitalizations each year in Toronto. Further analysis, looking specifically at air pollution just from traffic, found that 280 premature deaths and about 1,000 hospitalizations are the result of air pollution from traffic in Toronto. In terms of distribution, traffic-related air pollution, as you can see on this map, affects all parts of the city. The map specifically identifies areas in the city where there is greater or lesser exposure, or exposure zones as we call them, to identify them on this map by color. Exposure zones where we saw the greatest impact of transportation-associated air pollution are next to highways in blue and along major arterial roads in yellow. Using the available evidence, we can say that the exposure to air pollution varies with proximity to busy roads and the associated risk. So for example, air pollution impacts can occur at 100 meters, which is about the size of a city block, from an arterial road and that has traffic volumes of 1,500 or more vehicles per day. As you can see in yellow, these are roads all across the city, but to give you some sense of the specific examples, Islington or Markham Road, Steeles Avenue East, or Yonge Street would be examples we see here in yellow that are exposure zones. A second example of exposure increasing with proximity includes highways such as the 401 or the Gardiner Expressway, where air pollution is higher at distances up to 500 meters or 5 city blocks away from the traffic volumes that you see on these roads, which are more than 100,000 vehicles trips per day. And those are the ones shown in blue, as I said earlier. So that map gave you a sense of the distribution across the city, as well as the increased exposure that populations who are close to busy roads experience. More detail regarding the groups of people who are exposed is provided on this slide, where Toronto Public Health staff estimate that approximately 35% of residential areas and roughly half of all childcare centers, schools, and long-term care homes are located within a traffic-related air pollution exposure zone. So in summary then, because we now have a more fulsome understanding of the exposure and the health risk staff have developed a list of very proactive recommendations that put us in a good position to reduce the risks of traffic-related air pollution going forward. The recommendations are also very comprehensive. They advocate for changes federally and provincially because air pollution by its nature is a shared challenge. They also demonstrate how the city is being a responsible leader by looking at its own policies first. Specifically, we're looking at policies on new development and how it's designed, as well as operations in our existing facilities. To develop recommendations in an integrated manner across these many city services that are affected, staff consulted widely with planning, engineering, long-term care, children's services, facilities management, parks and recreation, as well as libraries. And then finally, they consulted externally with school boards and provincial ministries. Since I'm relatively new to this file, I really want to recognize the staff in Environment and Energy, Transportation and Health who have worked very hard on this consultation and have worked hard to develop a report for you that is technically sound and that puts the city in a strong position to manage the risk of air pollution in the future. That concludes the review of the technical work. I'll now turn it over to Kate to review the recommendations that we're seeking your approval on.
So there are many city initiatives that will help reduce TRAP, such as the Complete Streets Guidelines, the 10-year Cycling Network Plan, and the Climate Change Action Plan, Transform TO. However, there are important additional opportunities to reduce traffic-related pollution in Toronto. The report we're discussing today includes several recommendations to accomplish this, and the recommendations fall into three broad categories. The first is improving air quality by reducing emissions at the source. The second is modifying the environment in ways to reduce the amount of TRAP reaching people. So this would include modifying the environment in new construction, as well as reducing exposure in existing buildings in the city. And lastly, improving our understanding of the impact of traffic-related pollution on health through ongoing research and review. Many of the recommendations in the report focus on reducing the amount of pollution that's actually released into the air. The city's Transportation Services Division could pursue opportunities to improve air quality by giving priority to the implementation of measures identified in the Congestion Management Plan in high traffic emission zones where vulnerable populations live, work, learn, and play. Transportation Services Division could also evaluate the city's street sweeping service levels and identify the optimal standards to achieve good air quality along Toronto streets, particularly near sensitive uses. As well, Environment and Climate Change Canada could strengthen vehicle emission and fuel standards with a particular focus on heavy-duty diesel trucks, which we know are associated with much higher emissions than light-duty vehicles. The report also includes recommendations to reduce exposure to TRAP both in new buildings and existing buildings. The first of these recommendations is that the Environment and Energy Division and Toronto Public Health work together with relevant city divisions and agencies to develop feasible best practice guidelines on measures to reduce traffic-related air pollution exposure in new buildings, with the idea that these could be implemented on city sites, as well as promoted among designers, builders, and other professionals who are involved in development, planning, design, and construction in Toronto. These guidelines could include measures for buildings that will prevent polluted air from entering the building. For example, it could involve the placement of outdoor amenity areas away from high traffic areas, ensuring the layout of the building is such that areas that are most used are away from traffic, building design and appropriate placement of barriers that will disperse air pollution, and installation of high-performance air filtration systems. There are also several operational changes that can be made to improve indoor air quality in existing buildings, for example, to central ventilation systems. But further improvements to existing buildings could be made through retrofits. However, we know that these can be expensive. The provincial government should encourage the improvements in existing childcare centers, schools, and long-term care facilities through appropriate financial mechanisms and incentives. The last group of recommendations is around improving our understanding of traffic-related air pollution in Toronto. Currently, there are limited data on TRAP exposure. To obtain Toronto-specific data, Transportation Services, the Ministry of Environment and Climate Change, and Public Health Ontario are being requested to conduct air quality monitoring along Toronto streets and provincial highways and near buildings occupied by vulnerable populations. This would provide a better understanding of the extent of exposure to TRAP in the city. The Ministry of Environment and Climate Change could undertake a study to estimate the social, environmental, and health costs associated with TRAP and compare these with the costs of preventing emissions of and exposure to TRAP. This would support the implementation of effective interventions. And lastly, the Toronto Public Health Child-Friendly Policy Assessment Tool is intended to provide a child lens on a policy to better understand its potential positive or negative impact on child health. The use of this tool could identify additional measures that could be implemented to reduce negative impacts on traffic-related air pollution on children's health in Toronto. That concludes our presentation. Thank you.
Great, thank you very much. We'll just hold on board questions till we hear from the deputants. And we have two. We have one from Van McDonald, both from Hyde Park Tenants Association, and secondly from Angie Knowles, Hyde Park Tenants Association. Are you here? Great, come on forward. You have about 5 minutes each, and I'll kind of wave to you at the 5-minute mark, if this is your first time here and you don't know the rules.
It is.
Oh, but welcome, welcome, welcome.
Thank you, thank you, thank you. 2 weeks ago, if I knew I was being sitting here, I would have said somebody had had too much to drink, because we had no idea that we would be here. But a very, very nice gentleman from Toronto Public Health and one of your city planners had a great chat with us and sort of encouraged us to come. And I've been sort of given the health portfolio, and this is about, it's about seniors. My husband and I moved in 3 years ago to a gorgeous place in Hyde Park, and we were very comfortable, although we didn't want to move. And last December, we heard that there was going to be an enormous construction site all around the buildings that we were enjoying. There were pools and all sorts of wonderful things that gave our senior life joy in the latter years. And both of us are quite old. I should not be here. But I am here, and the reason I am here is for 33 years, I participated in a public health research project coming out of Ottawa, and it was an incredible education, and I volunteered my services to the tenants of Hyde Park because I have had quite an experience with bureaucrats, academics, you name it, and we were there. And we started up, it was the Center for Global Research and Education on Environment and Health. And it started with a very simple question 30 years ago, and that was, who is doing research on the accumulation of toxins in our children's tissues? Thinking we'd have the results of that question within a month. 35 years later, we got the answer. And that experience is what I want to share with you, because I volunteered my services, because my experience with politicians, presidents of universities, Princess Margaret Hospital, Sick Kids Hospital, you name it, it's there. And I just want to tell you that the results of our research are all now in the archives of Ontario. So we got the go-ahead from the Privy Council. We did our homework, and we really did our homework. And we literally formed a charity and started the Center for Global Research and Education on Environment and Health. And it was a global data center, and we had it all set up near York University, and we had graduate students working with us doing research. And I want to raise a really big issue right here, because one of the things that this public health, and I really enjoyed everybody talking tonight, is there is a huge gap in our research system, a huge gap. And that question, who's doing research into the accumulation of toxins in our tissues, was very simple. We thought we'd have it over in a month. I was also on a National Advisory Council for Fitness and Amateur Sport, and when they heard what we were doing, they said, well, while you're doing that, would you look into how polluted our Olympic athletes are? So we started out, and I will just say right now that I was shocked as a mother of 3 and just an ordinary citizen. When we went to people who should be able to give us the answers, they had not done their homework. And it wasn't that we were that smart, it was just that we couldn't believe the answers we were getting back. We moved from, this was in Ottawa, and we moved to Toronto, and immediately I was asked to go to Sick Kids Hospital because they had heard of what we were doing. And we ended up going to Princess Margaret, Sick Kids, presidents of universities, you name it, we went there. And we kept on getting stupid answers for that very, very simple question: who is doing research into the accumulation of toxins in our children? But we formed a charity. There was quite a bit of interest. The president of Sick Kids Hospital encouraged us. We got a lot of encouragement, and we were learning a lot, actually. And we started realizing that when you went to ask researchers about this, they'd sort of say, well, you know, we'd really like to do that, but we can't get funded for it. So we started looking into why they weren't getting funded. And it slowly began to, we began to realize that there was something blocking this research, and it was becoming very apparent that we were up against something that we didn't quite understand. I'm not going to go on anymore, except for the fact we did get funded by the Privy Council. We started this data center they looked at, and they thought it was so simple and so brilliant that no one would believe that it was, what's that? Okay, no one would believe that we actually had put this thing together. They funded us, Health Canada funded us, Environment Canada funded us, and we found out that our universities across this country, after we did a survey of every college and university in this country, are not producing PhDs in biochemical toxicology. They only work on fruit flies, frogs, and fish. They don't work on humans. This gap in our public health is what you people are battling right now. Because everything that you've talked to tonight, if you can't do research on our blood, urine, and tissue, and they can't, then we're not finding out the causes of our diseases and the reason we're getting sick. There's one lab in Quebec City.
Wrap it up. One last sentence.
There is one lab in Quebec City. They're world famous, and it's the only lab in Canada that is doing that.
Thank you very much.
Now, I'll pass it over to Angie, and...
Wait, hold on. No, hold on. Are there any questions of this particular deputant? Go ahead, Councillor Doucette.
Thank you, Van, for coming out today. Can I narrow this down a bit? You have given us, the two ladies, thank you very much. You've given us some information. Just want to make sure everyone knows you provided us. And one of your concerns right now, after all your years of work, is the fact that there are some proposals coming into High Park, which include 5 high-rise buildings and 2 mid-rise buildings, and you are concerned about the health of the children and the people during construction and after construction? Does that sort of narrow it down in a nutshell?
What narrows down is that we will never be able to, everybody in this high-rise development, and I say everyone, because we've been talking to a lot of people, are very concerned about their health. Mm-hmm. And the pollution that's going to be there. And when you see the design and you see the whole construction of it, there's one building going up right now and everybody's complaining about it. The noise is incredible. Now there's going to be 9 buildings, not just 6. And where I live, there's one right in front of us and we have no sunlight, anything. The whole design is right off. Now, the reason why I took on the public health is because I know how the system works. And in those 35 years, I know how the structure of organizations, schools, hospitals work. And I will be very honest with you, it's not linked. There's nothing linked in our systems. So
my next
what
question,
I'm doing right now is I'm trying to help people understand that I will help them get through. For instance, we've been to the city planners, they've been to our home, they stayed there 3 or 4 hours. We also have had, and I would like to name the gentleman because he's here tonight, he came up and we had an amazing talk and he agreed with everything that we had put together and thought. I'm 86 and I don't have a lot of strength left. I'm an artist that's still painting, doing commission work, and I know that I can't take this on. Now, Angie is my CEO and she's done an amazing job. She is corporation would take her on and they'd be darn lucky.
So
Now,
you
what
are
I'm
aware-
asking
so
her to do
you
is
are
take
aware
over.
right now
Yes.
that you're correct, that the province, who dictates some of our planning, does not look at the health impact on people during construction or after construction when it comes to city planning's envelope to approve developments. I'm not saying city planning has approved these applications because we're still through that process.
Yes.
But that's what you're trying to change, is that correct?
What we were trying to do is bring public health out, and when I started doing my usual research on something like this, as you know, we found that city planning and public health were separate, and they had to get together, and so we were able to get that together. I've also been to the Ontario Municipal Board, and they were shocked to find out that they had never, ever, ever had public health presented to them at the OMB. So there's a picture that is growing that needs to be put back together. And I think that public health should be number one. It's low men on the totem pole in Canada. It's shocking how low it is on the totem pole. So
thank you.
My experience is a little strange because we were so persistent. And where we are now in 2006, they canceled us, Harper canceled us. And we had an amazing data center going up with kids, graduate students from York University. It was amazing. We fought it for a year, and then we realized we were up against corporations who do not want this research done. So in being here today, I'm sharing with you actually an experience that not too many people had, but I'm also sharing you an experience that I would like to stay in this apartment. And my husband's 91, and we've had an amazing life, but I can't live in that place if they put up those apartments. And neither can my husband, and neither can anybody else. But let me turn you over to this lovely lady here. She's much more qualified.
Hold on, any other questions of this deputant? Okay, thank you. Now we can go to the lovely lady. Angie Knowles, Hyde Park Tenants Association.
Everyone. I'm not the world's best speaker, but just to tie into this, it's really about what we don't know about reducing health risks from traffic-related air pollution and many other pollutants. I'm a tenant that's been in the Hyde Park community in those high-rises for 35 years. We live in the largest city in North America, or in Canada, and the fourth largest in North America. And we have a major issue with public health, as Van mentioned. We recently were at a community meeting, which on October the 25th, and Sarah updated us on a community study that's going to be done in the particularly impacted area of these high-rise additions, of which we currently have 9 buildings and a couple of townhouses. With the ones that are going in across the street and the other 2 proposals, there'll be 9 more. It will double the density from approximately 5,000 to 10,000 people. And what I'm trying to do, and I'd like to thank, first of all, Sarah. I know she worked very hard at getting this community study pushed through extremely quickly and was successful. And what I'd like to do is just put a basic citizens' common sense, hopefully, appeal to bringing in Toronto Public Health, working with the planners and all the other appropriate people within the city, and hopefully to present something to the OMB or wherever we need to go to, or stall all of this until we resolve some of the unknowns that we're talking about, because it is going to impact, for example, vehicles. Double the vehicles, whether it's cars, TTC buses, school buses, vans, trucks bringing in loads because of proposed retail right within the setting that we're in, which will just compound everything. It'll affect all the air, of course, sunlight, trees, a provincial park that we live just up the street from that's almost 400 acres, and upset the balance of nature there, and all of our lives, whether it's human, animal, plant, and that all has an effect and creates a negative impact. And so the toxins that are released that have been mentioned already in terms of impacts on respiratory health, cancer, mutations as well, and also acid rain. So there's a number of impacts, negative impacts. We don't see the benefit of this for anyone that's living there, to be quite honest. To have a frilly recreation center really doesn't cut it when you're trying to live your daily lives and raise your children and take care of elderly people. We have daycare centers, we have a seniors home not far away, and schools and so on in the community. And so it's an appeal to please address this, help us and the city, because there's developments all over the city to deal with this issue of public health and make our lives better. Thank you.
Thank you very much for coming today. Anyone have questions? I do, but I'm going to move back to my seat, so hang on a second. Musical chairs here, forgive us. Are you aware, I have to ask questions, by the way.
Yeah.
Are you aware that we have invited Toronto Health to come and be a part of our character study for the apartment neighborhood?
I'm aware that there was an effort to do something of that nature, and what it looked like I didn't really know, so thank you for clarifying.
Well, we don't know quite what it will be either, but again, we're doing unique things in our area which don't normally happen.
That's great. Thank you.
I mean, the report we have before us today is more along the idea of the highways and locations like that. But you are right, there's a lot of development coming in. So are you aware also that the situation we're dealing in the area you're talking about, it's not just construction of however many towers come in or don't come in, it's actually also the property owners are having to redo their garage roof membranes, which is why we've lost far more trees and we look like the Sahara Desert right now.
Yes, I'm aware of that.
So it's as much as residents oppose the development coming in, even if it didn't, these trees would be gone and the desert would be there, and then they would be replanted, and another 50 years from now we'd go through the same thing. You're aware of
There is
those?
awareness of that,
Yeah.
yes.
Okay. It's very difficult asking questions, but thank you very much.
Yeah.
Thank you for coming out today, both of you.
Thank you.
Great, thank you very much for your deputations. We really appreciate it. I'll invite you to go back and sit in the audience and take it into the board. Are there any questions of staff? Councillor Doucette.
I am aware that with planning, we have guidelines on how close residential units can be built near railway tracks. Do we have any guidelines on how close residential units can be built by highways?
So through the chair, as you'll notice in the, through the chair, as you'll notice in the recommendations associated with the report, one of them is specifically with respect to speaking to planning and setting up appropriate guidelines, feasible and appropriate guidelines in respect of limiting traffic-related air pollution to a variety of different uses for different services, including homes.
But right now, we don't have restrictions. I know this is a planning question, I apologize. We don't have restrictions as to how close residential condo apartment buildings can be built next to a highway.
So through the chair, I'll have to defer again. My area of expertise is not so
Sorry.
much in planning.
Yeah.
I'm not sure whether my Environment and Energy Division folks, so I've got one staff person here who may be more knowledgeable than I am in respect of the planning guidelines.
As far as I'm aware, we do not.
So my understanding is, and again, maybe councillors who've gone through this more than I have, you can't build within 30 meters of a railway track, but I have a development coming within 3 meters of the Gardner. So is that, so that's really what you're saying, is we don't have a distance from a highway where people can build? Okay, I sort of answered my own question, I'm sorry, yes.
Yeah, that being...
I guess I'm trying to get a point across.
Yeah.
Yeah.
Through the chair,
that's one of the main recommendations that's coming forth, though, through
Right.
this report, is
Good.
that conversation actually should be held with the relevant city divisions, such that guidelines can be established so as to take into consideration the health impacts of traffic-related air pollution.
Thank you. That was all my questions.
I have one question. On one of the slides, and actually throughout the report, there's lots that you speak about, but one piece that I found that could be really strengthened is the best way to improve, reduce emissions at source is promote walking, cycling, and public transit. And the report is kind of light on that. I'm just wondering, is it because you assumed that work, or is it the subject of future work at a future date?
So I can let staff add to this, but certainly we have a number of other documents and strategies where we have tried to put forward the notion of the health benefits associated with increased cycling, walking, and public transit. So I think that's one part of the answer to your question. However, that is also included here with respect to traffic-related air pollution, that's an assumed method by which to reduce emissions at source. Reducing the emissions from actually happening in the first place would clearly be one method. Gail, I don't know if you have anything further you wanted to add.
So you're correct. When you think about it logically, reducing at the source through walking or cycling is the ideal solution. And I think to give credit to those who have done much more work on this than I have over the last several months, the existing documents such as the 10-year cycling plan, the Complete Streets Guidelines, Transform TO, those all do heavy justice to those reduce the source policy mechanisms. But to be fair, now that we have these results, I think that they will be ones that Planning and Transportation will use effectively in promoting those methods of reducing it at the source. So it wasn't an intent to diminish those obviously most effective roles, but to give credit to the previous reports that have been done.
So I just wanted to remind Council, as part of Transform TO, one of the objectives that you adopted was a 75% of trips under 5 kilometers or less should be walking and cycling by the year 2050.
Okay, so that work is assumed. This is on top of that. Okay, great. That's all I have. Any other questions? Okay, to speak, I have a technical motion just to put on. I don't really have a speech, so I'll just put this on the table. I'm not sure where this came from, but I understand it's necessary. Basically, it's submitted to City Council at the same time as the recommendations from the Parks and Environment Committee. I think this is a clerk, is this a clerk motion?
No, it actually came.
Okay.
We worked on it
It's
together.
peace, order, and good government motion. So that's that? Okay, that's all I have to say, but Councillor Doucette, do you have a...
Well, I want to thank my residents for coming out because this is a concern. I know this report is more around near the highway. We have a gardener running across the south end of my ward. We have major roads as well running throughout. And yes, we talk about heavy-duty diesel trucks on the highway, but we have these really, really big trucks right now lining up on some of my local streets to take all that dirt away right now just from those garage repairs which are having to happen. And they stand there, sit there, and they idle. I'm trying to find out, can they idle because they're to do with construction? I don't know. So we're looking into that. So the report is very good when it comes to what should a building be like when it's built, but our concern is the health of people while these buildings are being built, and also the health of the residents who are there now, and the health of the residents when they move in. We're losing light, we're losing open space, we're losing, I know it sounds silly, sky views, but by golly, looking at the sky on a beautiful day will make you smile, make you healthy, rather than looking at someone and see that and smell what they're barbecuing on their balcony. So it is going to change a lot of the health of people. I know that my residents are going through a very, very stressful time right now because we don't know what is going to be happening if construction will be going on for the next probably 7 years non-stop. 2 buildings are being built right now. Oh, garages are being done right now. 2 buildings are then being built. We have these two proposals right now, 3 towers and a mid-rise, 2 towers and a mid-rise, side by side. We know that something will be built, but we don't know what will be built. We know that residents are working with the developer. We know we're doing a character study of the neighborhood. But stress is a killer. And living with vibration from the construction, living with the noise and the dust. Yes, they can only build right now from 7 to 7. And I'll tell you, I'm sure other councillors get this. We get developers wanting exemptions to go further into the night, further into the weekends. I don't support those because residents right now have to already close their windows. And so not everyone has air conditioning. And in the summer, when you've got all this construction going on, that's not good for anyone. I read into this report that we want to get more people walking, we want to get more people riding their bikes, we want to get people out of cars. By reading that, and I'm not going to put words into anyone's mouths here, I think we'd be supporting transit which allows more people to walk to the transit, whether it's light rail transit, where you can walk to your station rather than having to get in your car and drive to a parking lot to get on the transit. That's what I think is a healthy city, not having to get in your car to get to your transit. You can go on your bike, you can park your bike at the subway, you can park your bike, hopefully at light rail, to get downtown or wherever you're going. What we didn't touch on was the street sweepers. And some are going to smile at me. So for anyone who wants to know, there's 2 different kinds of street sweepers right now we have across our city. There's this brilliant one, which we really talk about here in this report, which picks up all these minor little particles, which are on the roads because of the brake discs, the brake pads, just tire, crud, dirt, dusting. I know there's technical terms for these. I call these the sucky ones. Okay, I'm getting really down to nitty-gritty. I call those the sucky ones. The other kind of street sweeper we have is the ones with those big rotor things, which should get all the dirt and soil out of our curbs, which means then in my ward we wouldn't have foot-high weeds growing in the summertime, and it would mean the leaves that weren't therefore covering the sewer grates, which then causes flooding. So all these have different health issues. I am aware that in last city budget, we approved buying, I think it was 10 new street sweepers. Right now, there's not one which can do both. So I challenge any company to come up with one which can do both, because then you can pick up all your crud, your dirt, your leaves, and then you can go back and pick up all these particles, which also aren't healthy for people. So I got the sucky and I got the spinny things. Okay, I'm not a technical person, I'm not an engineer. I'm just me. So thank you for this report. It is a good report. I think it does go further. And as I say, I have high-rise buildings, probably another 2 coming in, which are within 3 meters. Their building is within 3 meters of the Gardner Expressway. The city tried to get 5 meters, and we weren't getting it for health reasons, we were getting it for maintenance reasons. So we could actually get in and fix the highway. Little thing called the OMB, building was put 3 meters away. So there's a lot of things we need to do. We do need to work with planning. We do need to improve where buildings are built. We've got daycares being put in buildings, as I say, just several hundred meters away from these highways, seniors' homes, other places. So great report for a start, still a long way to go. And with my residents, we will work on that health aspect, but as you both know, right now, there's no provision in any bylaw, any level of government to allow us not to build because of health reasons, the same as we can't not build because our schools are overflowing. But if we don't ask, we don't get, so let's keep bugging different levels of government. Thank you both very much.
Thank you. Any other speakers? Seeing none, so can we take both as a package, the technical amendment and the motions as presented by staff? All in favor? Opposed, if any? That's carried. We have 2 more items. They're both related to food security and food strategy. 22.4, there are no deputations, there are no presentations. I have a quick motion on this. You'll notice that I'll ask staff to put it on, the clerk to put it on the wall. Basically, it is to include the words and also reiterated support for living wage. That's been a debate that's at the provincial level right now. We have, as council, already indicated our support for the $15 minimum wage, and this is in that in line with what council has already approved. Any other questions on this? Seeing none, this is addressing food insecurity in Toronto. All in favor? Opposed, if any? That's carried. 22.5, food strategy. I have a motion on this one as well. That actually comes from the conference and us winning that award, the Milan Urban Food Policy Pact Award. Are there anybody else have any questions of staff? I'll just ask staff to put the motion on the table. Okay. This is a proverbial table. So basically what this asks staff to do is to report back on call it the Toronto Food Strategy Phase 2 or 2.0, and to basically use 2018 as the time, the beginning of 2018 as to how that would come forward, so that it is presented to the new term of council in 2019, and to make sure that there's broad public consultation on what that food strategy 2.0 would look like, and to make sure that that strategy also links to the poverty reduction strategy, strong neighborhood strategy, transform TO, economic development, and Toronto resiliency strategy, so that the new council, when it comes together, will have a coherent piece and will be able to take it to the next level. I think we've done a lot of good work with the first iteration of the urban food policy for Toronto. We need to take it up a notch. I think we need to move from the pilot and the experimental to the more systemic and the more broad-based. I think that's the challenge before us. This is a great report on what we've done to date. We can celebrate a lot of good things, and now we have to move beyond the pilots to see how we can do system-wide changes in food strategies. That's what this motion tries to encourage, tries to put before staff to do and to think through over 2018 into 2019. Okay, anybody else wish to speak on it? Okay, seeing none, all in favor of the motion, opposed if any, that's carried. That takes us to the end of the agenda, but may I just say this just before people leave. We do have Peter Wong is our representative on ALPHA. There's an ALPHA meeting, and ALPHA is the Association of Local Public Health Agencies. There's a meeting this Friday that is happening, and it's here in Toronto. If anyone would like to go, you can go. You will learn a lot and also be able to bring forward the Toronto perspective. I have the agenda here. If that entices you, feel free. We will find a way to get you there, even though it's in Toronto. Okay, thank you. This meeting is adjourned. Thank you, everyone.